Greetings everyone, my name is Farnoosh Kadri and I'm a third-year resident physician in obstetrics and gynecology at Beaumont Hospital, Dearborn. I'm presenting our research on elective induction of labor at 39 weeks. This is a QI initiative at our institution. To give you some background, our study focuses on primary cesarean section, which is defined as a cesarean delivery in a woman who has not had a previous cesarean section. For most low-risk pregnancies, cesarean poses a higher risk of mortality and morbidity. There has been a rapid increase in cesarean section rates from 1996 to 2011. There's a threefold increase in risk both in current and future pregnancies that are delivered by cesarean section. Primary cesarean section rate is a red metric for our institution, which is an urban-based community teaching hospital. The American College of Obstetricians and Gynecologists recognized incorrect diagnosis of labor dystocia and discrepancy in the interpretation of the fetal heart rate system as the primary reasons for the escalating cesarean section rate. Guidelines were issued in the Safe Prevention of the Primary Cesarean Delivery Obstetric Care Consensus, and these guidelines focused on allowing adequate time for labor to progress and emphasized the three-tier classification system for fetal heart rate tracing to categorize normal and abnormal during labor. This brings us to our goal, which is to reduce the primary cesarean section rate by 20% over the next 2 quarters in our institution. To achieve our goal, we adopted a two-pronged approach. We recommended starting elective inductions at 39 weeks on labor and delivery, and renewed emphasis on ACOG guidelines for prevention of primary cesarean sections. Historically, there has been a concern about increased cesarean section rates with elective induction of labor. A large randomized controlled trial published in the New England Journal of Medicine in 2018, the ARRIVE trial, which is an acronym for a randomized trial of induction versus expected management, showed that elective inductions at 39 weeks, irrespective of Bishop's score, was associated with a lower cesarean section rate, a lower risk of stillbirth, and a lower risk of hypertensive disorders of pregnancy. Before beginning of the implementation of the study, Beaumont IRB was approached and the study was deemed QI by IRB. The study was also approved by the department and 3 slots were allocated per week for the study patients. Individual physicians decided the methods and medications for the induction. Reproductive age group women who did not have a previous live birth and had an uncomplicated pregnancy participated in the study. Education sessions were also held by the resident investigators for the attending physicians, office, and hospital staff. In addition, educational printed material was distributed on labor and delivery, and posters were hung on the walls. I'd like to define some of the important details of the interventions that we did. We clearly defined the active phase of labor as 6 cm cervical dilation or more. Bishop's score was not a criteria for patient inclusion. This is a significant shift from before, as earlier, elective inductions were only done if the patient had a favorable Bishop's score. And how long did we wait for these patients to progress? Any patient who was 6 cm dilated, had ruptured membranes, and had adequate contractions, we waited 4 hours. And for a similar patient with inadequate contractions, we waited 6 hours before diagnosing a failed induction. What were the results at the end of the first quarter? 8 patients were recruited in phase 1. 4 patients had a vaginal delivery, 3 patients had a cesarean section, and 1 patient desired termination of the induction process. This translated into a cesarean section rate of 37%. There was no difference in the Bishop's score between the vaginal delivery and the cesarean delivery group. There were also no changes in the workflow on labor and delivery because of the scheduled elective inductions. Patients with vaginal deliveries had a longer induction. Their induction took about 30.6 hours versus 27 hours. And patients with vaginal deliveries also had a lower BMI. The BMI was 27 kilograms per meter square versus 31 in the cesarean section group. The cesarean section rate for our study was 37% versus the average, which is 32% for our institution. So what were some of the barriers to change? Premature diagnosis of failed induction and erroneous diagnosis of chorioamnionitis played a major role. There were some patients which were prematurely diagnosed with failed inductions and 2 patients with incorrectly diagnosed with chorioamnionitis. There was also the issue of subjective interpretation of fetal heart rate tracings. Patient anxiety also played a major role in the decision making. What are some of the important lessons learned from our study? Closer adherence to national guidelines improves patient outcomes. The starting Bishop's score is not a determinant of the final outcome, and when we allow adequate time for induction, there's a higher chance of having a vaginal delivery, as was evidenced by the patients who had a vaginal delivery in our study. Patient counseling and participation is critical. This emphasizes the importance of setting realistic patient expectations. This feasibility pilot highlights the challenges associated with the implementation of new advisories based on trials in real-life settings with varied patient and physician populations. We would like to thank the Obstetrics and Gynecology Department and Beaumont Hospital Dearborn, our nurses and office staff. Thank you, everyone. And thank you for listening to us and for your encouragement. Have a good day.